This presentation looks at cellular regulation. Remember that cellular regulation is the physiologic process of maintaining homeostasis through hydration and chemical balance through coordination efforts of the intact endocrine, hematologic, respiratory, and circulatory systems. Today we're looking at gestational diabetes and polyhydramnios and oligohydramnios. Your objectives for this unit. At the end of the unit, the student will be able to know and understand the pathophysiology, etiology, signs and symptoms, diagnostic criteria, and medical management of cellular regulation injuries of gestational diabetes, polyhydramnios, and oligohydramnios. Synthesize or evaluate the risk factors and effects of diabetes on pregnancy, and synthesize or evaluate the effects of excessive and insufficient amniotic fluid in pregnancy. Just as a reminder, since we are talking about diabetes, you need to make sure that you review your hypo and hyperglycemia symptoms. This is a little table that shows some of it to you. So what is gestational diabetes mellitus? It is any degree of glucose intolerance with the onset or initial diagnosis during pregnancy. All right, so the problem is that your metabolic changes are associated with pregnancy. A normal pregnancy is characterized by alterations in the maternal glucose metabolism, insulin production, and metabolic homeostasis. Now, glucose is the primary fuel for the fetus. So the maternal glucose crosses the placenta, but the insulin does not. Insulin needs increase during the first trimester for mom, and diabetogenic effect in the second and third trimesters. The graphic on this slide gives a great overview of gestational diabetes, and I encourage you all to read through it to help tie everything all together. High risk factors for gestational diabetes on the part of the mom are marked obesity, prior history of gestational diabetes, glycosuria, non-Caucasian women, prior birth of an LGA or stillborn infant, a maternal age greater than 25, hypertension, and a strong family history of type 2 diabetes. Maternal and fetal and neonatal risks of gestational diabetes. So mom can have hydramnios, which is the result of excessive fetal urination because of the fetal hyperglycemia. This condition could lead to premature rupture of membranes and the start of labor. Preeclampsia and eclampsia. This can occur especially if there are vascular changes, okay? And these vascular changes would be related to diabetes. This would be a severe form or somebody that had pre-gestational diabetes, mostly. Ketoacidosis, because of an increase in the ketones released in the blood from the metabolism of fatty acids. There's a decreased gastric motility and anti-insulin effects of HPL. Okay? Ketoacidosis during gestational diabetes would develop very slowly. There is an increased susceptibility to infections due to the increased glycosuria because this creates a good environment for bacterial growth. So we're talking mostly vaginitis or UTIs. Okay, A possible C-section birth, really if we see like polyhydramnios or macrosomia or a non-reassuring fetal status. And most women that have gestational diabetes actually will develop type 2 diabetes later on in life. Now for your fetus or neonate, their conditions are resulted directly from high maternal plasma glucose levels. Okay? Congenital anomalies like heart, central nervous system, and skeletal anomalies are all from high glucose levels. This is when mom has diabetes diagnosed early in pregnancy and can be a major cause of death for the fetus. Macrosomia is specifically related to the excessive insulin. When your baby is large, then you're at an increased risk of shoulder dystocia, where the baby gets stuck behind the maternal pelvis, and also traumatic birth injuries. Okay? If your baby were to weigh approximately 4,500 grams or more, then this would be the need for a C-section. Okay? RDS, fetal insulin decreases surfactant production. So your neonate would have RDS at birth. Hypoglycemia, this is because your baby is used to receiving a continuous supply of glucose, but as soon as they're born, that glucose is cut off. Hyperinsulinemia is very similar. It's the same thing. Your baby is used to continuous glucose, but then when they're born, the cord is clamped, their supply is cut off, but they still have all their remaining insulin that they had developed to combat the high glucose levels. Hyperbilirubinemia. This is the inability of the immature liver to metabolize the increased bilirubin that came from something called polycythemia, which is just an increased amount of red blood cells. Okay, infections, very similar to mom, having that higher glucose predisposes the baby to a variety of infections. And then polyhydramnios. So hydramnios, polyhydramnios, these terms are interrelated. But hydramnios in the baby could actually cause your baby to be small, or IUGR if there's not enough room to grow. Could also result in something like preterm labor if there's too much fluid and membranes rupture. For screening recommendations, all pregnant women are screened using a two-step approach. Step 1 is for everybody at 24 to 28 weeks of gestation. They undergo a 1-hour oral glucose tolerance test where they drink 50 grams of oral glucose, known as glucola. After they drink the glucose, then their blood sugar is checked 1 hour later. For this particular test, there is no requirement for fasting. Now, if the plasma glucose levels in step 1 are greater than 130, then they move to step 2. Step 2 is a 3-hour oral glucose tolerance test where they drink 100 grams of glucose solution. Before they do this, though, they are asked to fast overnight and go through at least 3 days of an unrestricted diet. They are told not to smoke within 12 hours of the test and avoid caffeine so that the blood glucose levels do not rise due to that. So when they come in for their procedure, First thing that's done is they take a fasting glucose, then they drink the 100-gram solution, then they'll check the glucose 1 hour later, then 2 hours later, then 3 hours later, for a total of 4 finger sticks. If 2 out of the 4 glucoses are greater than 130, mom is officially diagnosed with gestational diabetes. And here is just a picture of what that glucola looks like. And the baby say, no, don't drink it. Okay, so let's talk about the diet and glucose monitoring. So as far as dietary recommendations, the mom is recommended to take 2,000 to 2,500 kilocalories a day, but it is super important that we tell them to monitor. Okay, so the monitoring could be done in their physician's office, but they should also be taught how to self-monitor using the glucometer. Okay, why? Because monitoring is essential to assess the glucose control, but also determine if there's a need for medication. Okay, insulin administration requirements. So in gestational diabetes, the mom may need insulin to maintain normal glucose levels if she cannot consistently maintain them with just diet and exercise. Just diet and exercise, of course, would be preferred. Okay. If she needed insulin, we're definitely going to use human insulin because it's least likely to cause an allergic reaction. But we're going to have a combination of intermediate and regular insulins that could be administered. And then, of course, the insulin regimen is going to vary based on the needs of your patient. For oral hypoglycemics, they're not currently approved by the FDA for use in pregnancy, but metformin and glyburide are used in gestational diabetes. So here is glyburide, causes the maternal pancreas to produce more insulin. It does cross the placenta in smaller amounts, but it's not more effective than metformin. Metformin decreases the hepatic glucose production and increases peripheral sensitivity to insulin. It readily crosses the placenta in levels as high as the maternal levels. All right, so we need to, of course, always assess the well-being of our fetus. Okay, one thing that we can tell the mom to do is do daily maternal fetal status evaluation. Well, this would be your kick counts. All right, and we recommend that kick counts start at the 28th week of pregnancy because mom is feeling consistent movement at that point. She may have an alpha fetoprotein level drawn due to the risk of neural tube defects. This test is offered at 16 to 20 weeks gestation. Okay, an ultrasound can help identify any anomalies that there are. Typically in this case it would be done at 18 weeks and again at 28 weeks to check the fetal growth. The fetal biophysical profile. So remember that this is a combination of a non-stress test along with an ultrasound that looks at breathing, movement, muscle tone, and amniotic fluid volume. Then we have non-stress testing. So we usually do it twice weekly at 32 weeks. And a contraction stress test if we have a non-reactive, non-stress test, okay? Or they just might opt for the biophysical profile instead. Next is timing of the birth. So most women, no matter what type of diabetes they have, we really want them to go to term and we want them to have spontaneous labor. Okay, and this is especially true if we are well managed. In some cases, we may need to induce labor if we need to avoid problems related to the decreased placenta perfusion as that placenta ages. Okay, cesarean birth may be indicated if we see non-reassuring fetal status or macrosomia, like our big old baby there. All right, birth before term may be indicated for women with diabetes who are experiencing vascular changes, worsening hypertension, and evidence of IUGR. These are mostly going to be seen in your pre-gestational diabetics, not your gestationals. If preterm birth is imminent, then we like to do cesareans. And this should be considered if prenatal testing indicates a deteriorating fetal condition. Okay, so one thing we might do is the amniocentesis to check the lung maturity of the baby. For labor management, we're going to do hourly measurements of maternal glucose levels. We want to make sure we control the maternal glucose levels. In labor, we want it between 80 and 110. This will help us prevent neonatal hypoglycemia, and we can administer insulin if needed. Okay. If it's needed during labor, we tend to use a rapid-acting insulin via IV, but additional insulin may not be needed during the second stage of labor or immediate postpartum. So that takes us to the postpartum management. So what we know is that insulin requirements decrease postpartum. So once that baby's born, the condition almost fixes itself. Okay. The hormonal levels will fall after the placenta separates, and that means that the anti-insulin effect also decreases. Okay. So your postpartum women with gestational diabetes seldom need insulin. Elevated glucose levels can be treated with an oral antihyperglycemic. However, they are currently contraindicated if breastfeeding. We're going to reassess mom in 6 weeks postpartum to determine if her blood glucose levels are normal. If they are normal, then we reassess the mom at a minimum of 3-year intervals. Okay? And breastfeeding is encouraged. Hypoglycemia or diabetes in either mom or baby, whatever the situation may be, is not a contraindication for breastfeeding. Okay? It's definitely encouraged. Mom may just need like a pre-nursing snack since her insulin requirements have decreased. Infants of diabetic mothers, carbohydrate metabolism. At term, the newborn's cord glucose level is 15 milligrams per deciliter lower than the maternal blood glucose level. Birth causes an increased need for energy due to the removal of blood glucose supply and increased energy expenditure associated with the birth process and extrauterine life. Fuel sources are consumed quickly because of the work of breathing, loss of heat when exposed to cold, activity, and activation of the muscle tone. Glucose is the main source of energy in the first 4 to 6 hours of life. And as the liver and muscle stores of glycogen are decreased, the newborn will compensate by changing from carbohydrate metabolism to fat metabolism. Monitoring of an infant of a diabetic mother. So in order to prevent complications in our newborn, we need to be able to control the maternal glucose levels before birth. We need to closely observe the baby for the first few hours to the first few days. We are definitely going to monitor them for hypoglycemia. So this is going to be done with capillary heel sticks. A serum glucose level should be 40 to 60 in a baby. Infants with mild hypoglycemia should have early feedings, and it doesn't matter if it's bottle or breast. And in extreme cases, an IV infusion of glucose may be needed. So to prevent hypoglycemia in our baby, we routinely screen all at-risk infants within 30 to 60 minutes after birth and before feedings. Right? Infants of diabetic mothers should be screened within 30 minutes of birth. Serum glucoses are done per facility protocol. We want to initiate early feedings. So this is when it is especially important that we feed our baby right after birth in the delivery room. Then we'll reassess the glucose in 30 minutes after the feeding. Okay. If we need to do IV glucose, we will give 5% or 10% dextrose. Okay. Hypoglycemia nursing care. So our babies that are at risk for hypoglycemia are our preterm babies, babies of diabetic moms, and our small for gestational age babies. Signs of hypoglycemia in your newborn. You'll see temperature instability, apnea, irregular respirations, respiratory distress, cyanosis, tremors, high-pitched cry, seizures, lethargy, pallor, hypotonia, poor feeding, and sucking. So the primary intervention to treat hypoglycemia in the newborn is to feed the baby. All right, so next here we are talking about amniotic fluid complications. All right, so amniotic fluid complications are assessed with ultrasound using the amniotic fluid index. So what we're going to do is measure the vertical depths in centimeters of the largest pocket of amniotic fluid in all 4 quadrants surrounding maternal umbilicus, and then we total them all. Okay, so if you look at your picture to the right, you can see the 4 different quadrants. They find the deepest pocket of amniotic fluid, measured in centimeters, add them all together. That gives us our index. Okay. Other ways to identify these complications is to measure the fundal height and also attempting to palpate the fetus. Okay, so polyhydramnios, which you will also hear referred to as hydramnios, is technically more than 2,000 mLs of amniotic fluid. Okay, so for risk factors of developing polyhydramnios are multiple gestation, diabetes, RH sensitization, infections like syphilis, toxoplasmosis, CMV, herpes, and rubella, and fetal malformations such as swallowing or neurologic disorders of the fetus. For measurements, if we've done our amniotic fluid index, it would be greater than 25 centimeters. If we measure a single pocket, it would be greater than 8 centimeters. Okay. We'll also notice that that fundal height will increase out of proportion to gestational age, so it will be bigger than expected. When there's too much fluid in there, it's difficult to palpate the fetus or auscultate the fetal heart rate. In severe cases, we may see that the abdomen gets tense and tight, and the ultrasound could show large spaces between fetus and the uterine wall. For nursing care, when it's polyhydramnios, we usually just do supportive care unless mom is in distress or there are some kinds of symptoms of pain and dyspnea. In some cases, we may need to remove the fluid either vaginally or by using an amniocentesis. Okay. Maternal implications. So this is talking about if we do try to remove the fluid, a rapid fluid removal could lead to abruptio placentae. Okay, and this mom is also at risk for postpartum hemorrhage. For your fetal and neonatal implications, we're talking about malformations, preterm labor, preterm birth, a prolapsed cord, malpresentation, and a potential C-section. All right, oligohydramnios. So your oligo is a total of less than 500 mLs present. Okay, so we have too little fluid here. Risk factors include your IUGR, fetal conditions such as renal malformation, so this means that the kidneys are not adding to the amniotic fluid, post-maturity, and maternal hypertension. Your measurements here, so this would be an amniotic fluid index of less than 5 centimeters, or if we measure a single pocket, then it would be less than 1 to 2 centimeters. Okay, here for fundal height, it will be lower than what is expected for gestational age. And this baby with no fluid in the way is extremely easy to palpate. Maternal implications, this could lead to a dysfunctional labor and a slow progressing labor. Your fetal risks or implications, we're talking about with too little fluid, we might see fetal skin and skeletal abnormalities, cord compression, or fetal head compression. Okay, also pulmonary hypoplasia. Your nursing care. Okay. Let's see, nursing care. So this really comes into play during labor and birth. We'll want to evaluate a continuous EFM for non-reassuring signs. We may need to use maternal repositioning if variable D cells are noted. Okay. Assess the newborn for signs of congenital anomalies, pulmonary hypoplasia, or post-maturity. For treatment. Okay, so we may still assess this baby with your biophysical profile, non-stress tests, serial ultrasounds, and continuous EFM, of course, watching for cord compression. When the fetus is a term, we're probably going to want to induce labor, and we may use a possible amnio infusion. So here's your amnio infusion. So remember that the purpose is to increase the volume of fluid in the situations of oligohydramnios or anhydramnios, which would be no amniotic fluid at all. And we're relieving the intermittent umbilical cord compression that's causing our baby to have transient hypoxemia. Okay, what we're doing is if you look at the picture here, we are actually inserting an IUPC. Okay, remember that with an internal monitoring, we use the IUPC to specifically measure our contractions. So it just sits in that uterine cavity. It's not attached to anything. Well, this is the same device that we can use for amnio infusion. So once it's in place, we can administer up to 1,000 milliliters of sterile normal saline or lactated ringers, typically at a rate of 100 to 200 mLs an hour. We want to make sure that our fluid is administered at room temperature, so you can use a blood warmer if needed. And then we've got our nursing care. So of course, you're the one that's helping to administer the fluid. You're checking maternal vital signs. You're going to monitor the contractions and the resting tone. We've got continuous fetal monitoring going. Mom needs to maintain bed rest. We do want to make sure that we provide pericare and changing the pads out as we need to for comfort measures. But we also want to do I's and O's. So you probably have some Chuck's pads underneath her that you will weigh. And we want to make sure that the fluid that's taken in equals the fluid that's coming out. Okay? Remember, in the end, if you don't document, it wasn't done. The risks of this procedure include an over-distension of that uterine cavity and an increased uterine tone. So again, super important to feel that resting tone.